Good evening, my dear children. Hope you all are fine by God's grace. Today we are going to start our Unit 10, that is Nursing Management of Children with Genitourinary Disorders. And the main conditions that are coming under the Unit 10 are urinary tract infection, acute glomerulonephritis, nephrotic syndrome, Bim's tumor, obstructive uropathy, epispadiasis, hypospadiasis, and ectopia vesica. Today we are going to discuss about the urinary tract infection. It is one of the commonest infections that may be experiencing in throughout the age groups. So urinary tract infection is defined as an infection of one or more structures of the urinary tract. It may affect one or more structures of the urinary tract. And the etiological factors are organisms like Escherichia coli, Klebsiella, then Pseudomonas, Enterobacter, Proteus species, fungi. And the risk factors are, first is obstruction. The main risk factor is the obstruction of the urinary flow anywhere in the urinary tract and it will cause urinary stasis or urine accumulation. The neurogenic bladder, which may be associated with spina bifida. If the child is having a congenital disorder of spina bifida, there is a chance of neurogenic bladder. Neurogenic bladder means lack of the bladder control due to the nerve damage. Then vesicoureteric reflex. Vesicoureteric reflex means it is a condition in which there will be backflow of the urine to the through the ureters to the urinary bladder and kidney. Then renal calculi. Then children which is under immunosuppressive therapy. Then instrumentation or catheterization of the urinary tract. If there is any catheterization of the urinary tract, especially in the surgical cases. Then less water intake by the child as well as frequent voiding. Incidents are, UTI is the second most commonest infection in children, and it is more common in males than in females. However, the incidence is more in girls than boys because of the short female urethra and its proximity to the anal opening. Okay, because of the short urethra and proximity to the anal opening. So the classification are lower urinary tract infection and upper urinary tract infection. There are two categories: lower urinary tract infection and upper urinary tract infection. Lower urinary tract infection includes urinary bladder and urethra infection. If the infection is affecting the urinary bladder and urethra, it is a lower urinary tract infection. Then upper urinary tract infection, it includes infection of the kidneys, that is renal pelvis and renal parenchyma. So the commonest site of urinary tract infection is urinary bladder, and UTI may be acute or chronic. So next is pathophysiology. Pathophysiology, mainly during infancy, the causative organism of the urinary tract infection is bacteria. But after infancy, during infancy, the bacteria enters the urinary tract through the bloodstream. Okay, because of any infection in the bloodstream, it will be affecting the urinary tract also up to infancy. But after infancy, the bacteria will ascend through the urinary tract to the urinary bladder. Clear? The ascending of the organisms to the urinary tract through urethra is happening after infancy. So when the bacteria enters the urinary tract, there will be inflammatory changes within the urinary tract, and it will cause inflammation, and as a result there will be thickening and fibrosis of the uretrovesical junction. As a result of inflammation, there will be thickening and fibrosis, and there will be incompetency. It will result in the incompetency of the vesicourethral valve. Okay, this vesicourethral valve is it will facilitate the sphincter control. Okay, so as a result of the incompetency of the vesicourethral valve, the sphincter control will be lost, and as a result the reflex of urine or the urine will be flow back or flow upward. So there will be reflex of urine, and the organisms enters the upper urinary tract, and it will result in the infection of the renal parenchyma. So that is the pathophysiology. Then clinical features are, in infants there will be foul smelling urine, malaise, irritability, then unexplained fever. It is a main manifestation. Then poor feeding, then burning micturition. That means the infants may severely cry while passing urine. Then vomiting and diarrhea. Then toddlers and preschoolers manifestation are foul smelling urine, malaise, hematuria, then fever, dysuria, that is painful micturition, then increased frequency of urination, then abdominal pain, then flank pain, vomiting and diarrhea. Then in school age and adolescence, there will be foul smelling urine, malaise, hematuria, then fever and chills, dysuria, then increased frequency of urination, abdominal pain, flank pain, then avoiding urination, and costovertebral angle tenderness. So these all are the manifestations in school age children. Then diagnostic evaluation or history collection for any respiratory infection, for any associated respiratory infection, onset of signs and symptoms, then details of the pain. And in physical examination, we have to palpate for the abdominal tenderness and flank pain. In urinalysis, we have to look for the WBC, RBC, then bacteria, and to test for certain chemicals like nitrate in urine. Then we have to send for urine culture. We have to clean catch. That is, in clean catch urine specimen means midstream urine specimen should be collected to identify the causative organism and find out the suitable antibiotic for treatment. So to find out the suitable antibiotic for treatment and to assessing the correct causative organism, we have to send the urine for urine culture. Then blood investigation, a complete blood count and blood culture may be done. ESR and C-reactive tests are also done, which may be elevated due to infection. The ESR and C-reactive protein will be elevated. Then renal ultrasound. So that means renal ultrasound is done to identify the conditions like hydronephrosis or accumulation of urine inside the kidney. Then CT scan of abdomen to identify the inflammation of bladder. Then voiding cystourethrogram to rule out the bladder and urethral anomalies. If there is any bladder or urethral anomalies, especially the loss of sphincter control, we can find it out by voiding cystourethrogram. Then intravenous pylorography. We are visualizing the urethral tract as well as the kidney. Then management for mild bladder and kidney infection, oral antibiotics like amoxicillin, ceftriaxone, doxycycline, then fluoroquinolones for 7 to 14 days. A follow-up urine culture is done after 48 to 72 hours after the initiation of treatment. Then to relieve burning pain during micturition, phenazopyridine hydrochloride or pyridium may be given. Then for severe urine infections, if the child is too sick to take oral medications or drink enough fluids, hospitalization may be required. Then during hospitalization, intravenous antibiotics and fluids are given. The nursing management, we have to encourage the fluid intake to dilute the urine and flush out the bladder. So it is the main therapy. Then intake and output chart should be maintained. Then weigh the child daily. Then educate the parents to give slightly acidic fluids to the child like apple juices, orange juice, lemonade, etc. as they make the urine acidic, thereby rendering it suitable for the growth of microorganisms. So then prevention, maintaining hygiene, then regular bath, then clothing and undergarments should not be too tight. Always remove the soiled or wet clothes immediately. Then encourage the child to drink plenty of water, then or fluids. Then children should be asked not to hold the urine for long time. Okay, so these are the preventive measures. So hope you all understood the urinary tract infection very well. The next we are going on to the second condition, acute glomerulonephritis. So acute glomerulonephritis, it is an acute inflammation or sudden inflammation of the glomeruli within the kidneys, and the inflammation results in acute renal failure. So this is the acute glomerulonephritis is an indicator to the acute renal failure. So etiology are bacteria or viruses. Then most common organisms is beta hemolytic streptococci. Then the primary site of infection is usually throat or skin, after which nephritis occurs. Then incidence is twice common in it is twice common in males than in females, and mostly seen in children of age 5 to 8 years, and the peak incidence is seen in 7 years of age. Then pathophysiology, because of beta hemolytic infection, okay, or because of any rheumatic fever or rheumatic heart diseases. Okay, the causative organism of rheumatic fever is group A, beta hemolytic streptococci. So because of any cardiac infection or any respiratory infection, beta hemolytic infection may persist in the body, and it will cause the activation of the immune response, and as a result of the activation of the immune system, there will be antigen-antibody complex, and it is deposited in the glomerular filtration membrane. So as a result, there may be the after effects will be two. First is inflammatory attack on the glomerular membrane. It will affect the glomerular membrane, and the enzymes are released from the damaged glomerular cell wall membrane, and it will cause increased permeability and passage of protein and RBC in the urine, and glomerular filtration rate will be increased. Okay, so this is one route. So inflammatory attack on the glomerular membrane, it will result in the enzymes release of enzymes from the damaged glomerular cell wall membrane, and it will result in increased permeability and passage of protein, that is loss of protein and RBC in the urine, and glomerular filtration rate is increased. Then the second pathway is because of the antigen antibody complex in the glomerular filtration membrane, coagulation system is activated. It will result in proliferation of cells in the glomerular membrane, and it will result in decreased renal blood flow. Because of the proliferation of the cells, there will be decreased renal blood flow, renal insufficiency, and it will result in retention of water, sodium and other waste products. Okay, so these are the two pathways. Then clinical manifestations are hematuria, then oliguria. I hope you all know what is hematuria and oliguria. Hematuria is blood in urine, oliguria is decreased urine outflow, then tea-colored urine due to hematuria, then periorbital edema. Okay, then anasarca, that is whole body edema, hypertension, then anorexia, diplopia, then abdominal pain, fever, fatigue and lethargy. Then diagnostic evaluation are history collection to rule out the primary site of infection, then physical examination, the blood investigation like WBC is elevated, blood urea nitrogen and creatinine is elevated, ESR is elevated, then hemoglobin percentage is decreased because of the dilution of the blood. Then and also there is a chance of hemorrhage. Then ASO titer is raised. Then culture from primary site of infection such as throat or skin is helpful in identifying the causative organism. Then renal biopsy may be done if there is no clear diagnosis from other tests. Then management, first is medical management. The aim of management are to identify and treat the source of infection, to maintain the fluid and electrolyte balance, to maintain blood pressure within normal range. So first, the management includes the children with normal blood pressure and urine output can be managed at home with specific antibiotics. We can give specific antibiotics at home itself. Then children with generalized edema or anasarca, hypertension, hematuria, so these all are danger signs. So they have to be hospitalized because of the probability of developing renal failure. There is a chance of developing renal failure in generalized edema or anasarca, hypertension and hematuria. If the child is having normal BP and normal urine output, we can manage them with antibiotics at the home itself. But if there is generalized edema, hypertension and hematuria, we have to hospitalize them because there is a probability of developing renal failure. Then complete test to be given during the acute phase. Then hypertension to be treated with antihypertensives like hydralazine and methyl dopa. Okay, if there is hypertension, we can give hydralazine and methyl dopa. Then generalized edema requires administration of diuretics. We can give the administration of diuretics in anasarca like furosemide or Lasix in a dose of 1 to 3 mg per kg per dose orally 2 to 3 times a day or intravenously, and it should be repeated after every 2 to 6 hours. According to the severity of the condition, we can give in 2 hourly or 6 hourly. Then sodium, potassium and fluid intake may be restricted to treat mild hypertension. To treat hypertension, we have to restrict sodium, potassium and fluid intake. Then a course of antibiotics is administered to eradicate the infectious agents. Then in presence of severe azotemia, protein intake may be restricted. Okay, what is azotemia? Azotemia means increased level of uric acid, that is amino acid in the blood. In the nursing management, monitor intake output chart. Okay, then measure the abdominal girth to rule out the ascites. If there is ascites, the abdominal girth will be increasing day by day. Then monitor vital signs. Then monitor the blood pressure because the child is having a chance of developing hypertension. Then monitor the fluid intake and restrict the fluid intake. Then salt and potassium intake if prescribed. So we have to restrict the fluid intake and also salt and potassium. Then prevention of infection, then preventing skin breakdown and meet the nutritional needs of the children and emotional support. So these are the nursing management in acute glomerulonephritis. So hope you all understood the urinary tract infection as well as acute glomerulonephritis. Thank you.